Hello, my name is Rick Kronick. I'm a member of the consulting team, and it is my pleasure today to provide you some background material on financing considerations for discussion at the August 13th Healthy California for All Commission meeting. I want to acknowledge at the outset the contributions of Laura Lucia and Ken Jacobs at the UC Berkeley Labor Center, who have been instrumental in preparing this presentation. I want to cover four main topics. First, provide an overview of how financing works currently. Second, a brief discussion of the importance of maintaining federal and state funding and a little bit of information on some of the issues in doing that. Third, discuss potential criteria to evaluate options for revenue. And fourth, consider some potential revenue options and how they stack up against the criteria that I will have discussed. Before I start the presentation, there is a bit of a cart and horse feature to the discussion that you'll be having on August 13th. You'll be talking about how to arrange financing for a system of unified financing without yet knowing how much money such a system will actually need. In 2019, we spent around $437 billion on healthcare in California. How much money will be needed under unified financing? Well, that depends on a variety of decisions that have not yet been made around issues such as provider payment, which we'll be talking about in September, around the role of intermediaries, which we'll be talking about in October, around benefits and eligibility, the topic of November, cost containment, which will be discussed in December. So we don't know how much money will be needed. And actually, even when decisions eventually are made by the governor and the legislature, there'll still be uncertainty. This slide shows a graph from an article written by Christopher Kai and colleagues, published in January of this year, summarizing the results of a variety of estimates of the amount of the effects of single payer proposals on healthcare spending. And the blue line is the net effect. And so you can see the 20 or so studies had a variety of results. The midpoint is at about a 3% savings. Over on the right, there are a few studies that are estimating a 10% savings. Again, we don't know how much money will be needed in California. Maybe thinking somewhere between 3 and 10% savings, so $13 to $44 billion savings is reasonable. For the purposes of the discussion today, I don't think it matters much exactly how much money is going to be needed. That the discussion that you'll be having on August 13th will, I hope, be a fruitful discussion, regardless of whether there's a 3% savings or a 10% savings or no savings. But it's important, I think, on sort of cart and horse part to get this straight. We don't know exactly how much money is needed, but we can still talk about the advantages and disadvantages of various ways of raising money. Let me start now with an overview of financing. This pie chart shows the distribution of the $437 billion that was spent in 2019 based on what pockets the money went through before it got to healthcare providers. On the right-hand side of the pie chart are primarily federal and state spending, about half of the spending altogether. Federal Medicare spending 17% of the total, federal Medicaid 14%, other federal programs, including the Indian Health Service, military health system, about 6%. The state, 6%, primarily Medi-Cal, but some other programs as well, some county spending. And there is a bit of federal and state spending in that other 9% slice as well. I'll talk about this more in a couple more slides, but mostly the right-hand part of this pie chart, I'm going to assume, and I hope you're going to be willing to assume, we're sort of leaving alone, that under unified financing, those funding sources would continue largely as they do today. And it's the left-hand side, those two slices, the private and public employers, 24%, and money coming from households, 21%, that will be the subject of change and a lot of the subject of your discussions on August 13th. So this next pie chart is those two slices, the household and the employer slices, expanded somewhat. So 197 billion of the 437 billion is coming from employer paid premiums, about half of the 197 billion, from worker premiums, from other premiums paid by households for Medigap policies, for individual coverage through Covered California, for premiums for Medicare Parts B and D, and then a slice of this 197 is out-of-pocket spending, much of which is coming from people who are covered by private insurance and they're paying copays and deductibles, some coming from Medicare beneficiaries paying copays and deductibles, and then other spending for services such as long-term care and dental, which are typically not covered by either private insurance or Medicare. Employer premium slice, the 51%, and the worker premium slice, the 13%, add up to 127 billion in 2019. And a lot of the focus of the rest of my presentation and the focus of, I think, much of your discussion on August 13th will be about how that 127 billion should be replaced. And again, if there's some savings from the system altogether, maybe the whole 127 billion doesn't need to be replaced, but much of it will need to be replaced if employers are no longer directly involved in the purchase of insurance. And then the two other big slices on this pie chart, the 11% for other household premiums and the out-of-pocket spending 23%, and a little workers' comp, they together add up to about 66 billion. Some or all of which will also need to be replaced. The existing healthcare financing system is extremely regressive. This graph is from work done by Emmanuel Saez and Gabriel Zuckman, who are economists at UC Berkeley, and shows the incidence of a variety of taxes by household income. So the x-axis over on the left, people in the lowest 10 percentile of income. The next hash mark is 10 to 20th percentile. And as you go to the right, you get to very high income people. There are a few important messages from this graph. You know, starting on the bottom, you see that sales taxes are quite regressive. They take a larger fraction of income from low income people than from upper income people. Corporate and property taxes, slightly, somewhat progressive. Payroll tax is pretty flat. This is Social Security and Medicare payroll tax, pretty flat throughout most of the income distribution. But then because Social Security has a cap on the amount of income that is subject to payroll tax, actually becomes regressive, in which upper income people pay very little of their income. Individual income taxes are the most progressive part of our tax code. But then importantly, this health insurance poll tax, or what Saez and Zuckman call a poll tax, I would call it a head tax, I think is a easier understanding of it. And this is the amount of money that employers and employees are paying for employer-sponsored insurance. And as you know, it's a flat amount that doesn't vary by income. So an employer that's offering employer-sponsored insurance is paying in the neighborhood of $20,000 for a family insurance policy, and paying that same amount for someone at $40,000 income as for someone at $150,000 of income. And economists will tell us, and they're sort of mostly right on average, that that $20,000 is coming out of the employee's compensation. And so it's a much larger fraction of compensation for the lower or moderate income employee than it is for the higher income employee. And you see that in the shape of this dark blue segment on the top of the graph, that the health insurance head tax, what's labeled here poll tax, is an extremely regressive way of financing healthcare. And as you think about moving to a system of unified financing, sort of fixing this piece of it should, I think, be an important consideration. On average, in 2018, California workers were paying 14% of single coverage and 27% of family coverage, with employers paying the rest. Again, as I mentioned on the last slide, the employer part, for the most part, is really coming out of employee income. Single coverage averaged $8,700 per year, about $4 an hour for somebody working 40 hours a week. And family coverage averaged almost $21,000 a year, or $10 an hour for a full-time worker. So you all know this already. Healthcare is really expensive. On average, employers in California were paying 8% of payroll for the employer part of health insurance, another 2% or so paid by employees. That 8% varies a lot by characteristics of the employer. In the bottom part of this slide, you see that state and local governments are paying a lot more as a percent of payroll than private industry. They tend to have better benefits and lower paid workers. Larger firms are paying a larger fraction of payroll than smaller firms. Some of the smaller firms don't offer insurance at all, which is part of what brings those numbers down. The numbers on the bottom are national and from a different data source than the 8% California number on the top. So I think that the 8% of payroll is our best estimate for the fraction of payroll paid by California employers now. The numbers on the bottom are illustrative of the kinds of variation that we would see in California. I want to spend a couple of minutes helping you think about what would happen to employer contributions if employers were no longer contributing to health insurance. So if employers were no longer buying health insurance directly, what do we think would happen? Economists would say that in the long run, the amount that employers are currently contributing would go back to workers in the form of increased wages. So that if an employer is paying $5 or $6 an hour now for health insurance, that in the long run, workers' wages would increase by 5 or 6%. But in the short run, that is not likely to happen. And even in the long run, it's not certain that that will happen. And in the short run, employers might end up keeping some of the windfall if they were no longer contributing to health insurance. And to the extent that it went to workers, it's not at all clear how that would be distributed between lower and moderate income workers who tend to have less bargaining power and upper income workers who tend to have more bargaining power. So part of the answer to the question of what would happen if employers no longer contributed depends on state policy. Says and Zuckman have recommended that the state pass a law that would require employers to pass on the $5 an hour or whatever it is that they had been paying directly to workers. If the state were to enact such a law, there's a question of how effectively it might be enforced, but it would almost certainly move the long run outcome somewhat in the direction of what might happen in the short run. To the extent that wages do increase, if employers were no longer contributing the $100 billion that they are paying, and more or less, and workers no longer the $20+ billion that they are paying, wages would increase, again, depending on whether or not there was a state law and kind of how quickly the long run turned into the short run. And the first thing that would happen is that federal payroll and income tax revenue would increase. Because if there were a $127 billion increase in the taxable wage base, about 30% of that would go to the federal government in the form of increased payroll taxes and increased federal income taxes. And the state could certainly try to negotiate with the federal government and say, oh, you just got this, $40 billion windfall. We want some of that money back. This would probably be a very, very difficult negotiation to be successful in, although maybe not impossible. And then finally, thinking about kind of what would happen if employers were no longer contributing directly, the answer certainly depends on what else, if anything, employers were doing. So, one possibility would be the proposal that Senator Warren made when she was running for the Democratic presidential nomination. And Senator Warren is to be commended for putting forth a very specific proposal. And I applaud many of the specifics that were in that proposal. But the financing part was problematic from my point of view. That she proposed that each employer who's providing insurance now would pay a head tax of the same amount that they're paying now. So if an employer is paying $10,000 per worker now for health insurance, they would pay a tax of $10,000. And if they were paying $14,000 per worker now, they'd pay a tax of $14,000 per worker. That maintains the current inequities, the regressive nature of our healthcare financing system. And certainly one of the potential advantages of moving to unified financing is reducing those inequities. So a second possibility would be a flat percent of payroll. I'll talk about this more in a little bit, but a 10% payroll tax combining the employer and employee portions. And that would improve equity to the extent that workers got wage increases equal to the current amount that employers are paying, minus then this flat percent of payroll. Low-income workers would end up with a net increase in income. High-income workers would end up with some net decrease. And then if there were desire to make that payroll tax even more progressive, the first, and for example, $20,000 of income could potentially be excluded. I'm going to spend one slide on federal financing. For the purposes of the discussion today and on August 13th, we are assuming the federal government will pay California's Unified Financing Authority the amount that the government would otherwise have paid for Californians on Medicare, Medi-Cal, and those receiving premium tax credits through Covered California. For consideration, there is certainly a question about how realistic is that assumption. In the first held the California for All Commission meeting in January, Commissioner Schneider, much closer to Washington than many of us, suggested that he thought it was extremely unlikely that the government would agree to turn over Medicare financing to California. There will be a new Congress and perhaps a new president come January of 2021, and that we may have more information about how possible it might be. Certainly there'll be many questions about what California would need to agree to in order to receive financing. Also questions about how much can be done through administrative flexibility with waiver programs, either Medicaid, the Affordable Care Act, marketplace subsidies, or Medicare, and to what extent statutory change is required. Answers to that depend in part on how much flexibility we think California would need. My own sense, for what it's worth, is that it'd be very hard to make this work without statutory change, but that is certainly a longer discussion. Whether this is done through statute or waivers, negotiating an adequate rate of increase in federal funding will probably be key to the success of this program over time. Rate of increase should certainly vary. With changes in population. On the Medicare side, changes in the number of elderly and disabled people. On the Medicaid side, potentially changes in economic conditions. And then there are some smaller but still important questions about other federal programs, the Indian Health Service, TRICARE for the dependents of active duty military and military retirees, Veterans Administration, and kind of how these programs should work in concert with unified financing in California, and how, if at all, money should change. In the last slide on financing, before I move to the consideration of the criteria and principles, is some consideration of how reserves might be created for a system of unified financing. Unified financing would need reserves for two types of contingencies. First, if expenditures are higher than expected, and second, if revenue lower than expected. We think of the current pandemic, regardless of the revenue sources, potential revenue sources, and we'll discuss those in a few minutes. Any of those sources would probably have taken a big hit in this pandemic. And sort of what would the system of unified financing do then? Private health insurers are typically required to maintain reserves of at least 2 months of expected spending. In California, that'd be about 70 billion. Insurer premiums are not subject so much to the revenue fluctuation, and so arguably reserves for the system of unified financing would need to be greater than the reserves just to cover expenditure fluctuations. One potential idea for funding reserves or for making this possible would be to try to negotiate a line of credit with the federal government that says, if something really bad happens, the unified financing system could call on that line of credit. Clearly then questions of what the terms are, how long the system would have to repay that. Others may have other ideas, but this question of reserves is part of the, how do you make unified financing work? So to summarize this part of the presentation, in 2019, California health expenditures were approximately 437 billion. As I said, we don't know exactly how much money is going to be needed, but probably somewhere close to that. Maybe there'll be savings of 10 to 44 billion or something like that. About half of this money currently comes from federal, state, and local governments. For today's discussion, we're assuming that the government money will continue, and focusing primarily on how to replace the 127 billion that employers and employees are currently spending for employer-sponsored insurance, and the 66 billion that households are spending in out-of-pocket payments and other insurance premiums, or at least the portion of that will still be needed after whatever savings are created. And then, as a reminder, employer payments for health insurance are effectively a head tax on the wages of workers and are highly regressive. I want to move now to consideration of criteria by which we might evaluate alternative options for financing. And start by noting that the legislation establishing the commission doesn't make this consideration a specific charge to the commission. But in the discussions we had with all of you in between the first and second meetings of the commission, we heard a lot of support and interest in some discussion of financing, and that motivates the slides that follow. I have two slides on potential criteria for evaluating options for raising revenue. And this is the first. There are 4 criteria here. There'll be 3 on the next slide. And these are suggested as potential ways of trying to figure out whether a given way of trying to replace the 127 billion in employer spending or 66 billion in household spending, whether they're desirable or which ones are more desirable than others. And these criteria come from basic principles in tax finance policy with a few little fill-ups here and there. And the first, no surprise, equity, that financing should be equitable. Different people will have different understandings of exactly what that means. Here I suggest a couple of important principles: whether revenue sources reflect households' ability to pay, and whether similarly situated households and firms are treated similarly, which in today's healthcare financing, neither of those principles is well satisfied. Adequacy, certainly there's a set of needs. Again, we don't know whether it's 197 billion or somewhat less than that, but whatever the needs are, the financing should be adequate to raise revenue to meet those needs, and should be able to grow over time as those needs grow. And we haven't talked at all about the rate of increase in healthcare spending. We'll get to that in later meetings. The third potential criteria here, do no harm. I spent quite a bit of time a few slides ago describing what would happen if employers stopped, what might happen if employers stopped contributing to health insurance. And one possibility, depending on how financing is arranged, is that workers' incomes might go up by 100 billion, or taxable incomes might go up by 127 billion. And that would result in big windfall to the federal government in increased payroll and federal income taxes. And trying to avoid that windfall seems like a desirable thing. Fourth here, minimize economic neutrality, minimize economic distortions. Some taxes will have larger effects on the operation of the economy, on decisions that individuals and firms make, and on the competitiveness of California industry. Sort of avoiding negative effects seems desirable. Fifth, stability. Other things equal, taxes that create a more uniform revenue flow over time are to be preferred to taxes that gyrate up and down in the revenue that they create. Simplicity, minimize administrative costs and burden. Do we know how to do this? Are there new administrative systems required, and what's the cost both to the government and to individuals or corporations of paying these taxes? And then last on this list, healthy behavior, using tax policy to try to discourage bad corporate behavior that contributes to poor health, and to discourage individual behaviors that contribute to poor health. Here are some questions, balancing the desired behavioral change with need for revenue. If you have a tax and it's effective in discouraging unhealthy behavior, and the unhealthy behavior goes away, the revenue goes away. And then also trade off with equity. Some taxes in this in this realm, such as a soda tax, are going to, the incidence will be felt most directly on low-income people, and are the ways of mitigating that. I want to consider now how a number of potential broad-based financing options stack up against the 7 criteria that I just showed you on the last 2 slides. And I'm going to be considering 5 broad-based financing options. You might ask, well, why these 5? Mostly, these are the only 5 that we could think of that would come anywhere close to be able to be scalable, to raise enough money to fill in for the 127 billion in employer and employee payments and the 66 billion in household payments, or at least the parts of that will still be needed. There are a variety of supplementary financing options that certainly could be used to fill in parts of that. Options such as an increase in the income tax on high-income Californians, Californians with income over $1 million or an income over $3 million, some surcharge on that income. Tax on unrealized capital gains, or a wealth tax, or soda tax, or carbon tax, or maybe a tax on tourism or airport fees. There are a variety of other approaches, none of which in any feasible tax rate could raise more than $10 billion a year, and most of them considerably less. When you kind of add up supplementary potential revenue sources, they could add up to 30 or 40, or maybe in a real stretch, 50 billion. So not to be ignored, but certainly not going to be enough to do the major part of the job of replacing the employer and employee premiums. So these broad-based financing options, as far as we're aware, are kind of the main options. So the first of the broad-based financing options is a payroll tax, and I've talked about this already. if workers' wages were increased by the amount that employers are currently paying and then reduced by the amount of the payroll tax, this would be certainly more progressive than the existing system. It could be made more progressive still if the first, for example, $20,000 of wages were exempt from the payroll tax. The payroll tax is quite scalable. 1% payroll tax was estimated to raise $12.5 billion. A little over 10% would cover the $127 billion that employers and employees are currently paying. To the extent that workers' wages were increased on the one hand and then reduced by the payroll tax, on net there would be no change in taxable income, although some decrease for high-income workers and an increase for low-income workers, but would retain the federal tax advantage of the employer-paid system. On neutrality, the current system finances health care with a tax on labor, but not on capital, and so is not neutral in labor relative to capital. Payroll tax would maintain that lack of neutrality. Extending the payroll tax to independent contractors and sole proprietors would increase equity and avoid incentives to turn people into independent contractors and sole proprietors. As with really every thing I'm going to show you, payroll tax revenue would fluctuate with the economy. It is administratively relatively simple, doesn't have any direct impact on improving equity through changing behavior. A second possible financing option is a flat tax on labor and capital income. This has been proposed by Sayers and Zuckman, who I mentioned previously. This is a tax that is broader than the payroll tax. Payroll tax just taxes wages. Here the idea would be to tax as many sources of income as possible and to tax them equally, to try not to advantage one source of income over another. So it'd be like a payroll tax, except instead of just applying to wages, it would apply to all forms of compensation, be a similar size, same size tax on corporate profits and on interest income. Sayers and Zuckman estimate that a 1% tax would raise $18 to $20 billion a year. Again, all these are pre-pandemic estimates. This tax would largely retain the federal tax advantage of the employer-based system and has advantages over the payroll tax in not favoring capital over labor. It minimizes economic distortions by treating all income sources the same. It would fluctuate with the economy. On simplicity, well, this is new and a little different, never done quite this before, and so some changes would be needed. But we do already have a corporate income tax, and we have examples of payroll taxes, and again, no direct impact on healthy behaviors. A third potential option for a broad base financing source is a gross receipts tax on businesses' revenue. So this would work that every time a business sold anything, it would pay the gross receipts tax. This is effectively a sales tax on firms, and like other sales tax, the incidence is generally regressive. It's quite scalable. A 1% gross receipts tax would raise $40 billion a year. So even a 3% tax would raise $120 billion. It'll replace employer and employee current contributions to health insurance. And in that respect, seems to be quite attractive. A couple of big concerns about a gross receipts tax. First, if wages increase, if again, employers increase workers' wages, then the first thing that happens is everybody pays a lot more money to the federal government. That seems undesirable. Bigger concern is the regressivity of it and the effects on encouraging vertical integrations of firms. If a farmer sells her crop to a small distributor, she'll pay the 3% tax. And if the small distributor sells that product to a large distributor, it pays the 3% tax. and then the large distributor sells it to a supermarket, it pays a 3% tax. The supermarket sells it to the consumer, the supermarket pays a 3% tax. So by the time the consumer has bought this thing, it's had 12 cents of taxes applied, and that's kind of part of the regressivity. And also the supermarket has a big incentive to try to buy up the large distributor and the small distributor and maybe even the farmer. It's also got a big disproportionate effect on businesses with large cash flows and low margins. It would require a new tax collection infrastructure. The fourth broad-based financing option to consider is sales tax on services. As you all know, in California, we tax goods today, but we don't tax services. Sales tax on services, like all sales taxes, would be regressive. It is scalable. 1% on services, excluding the ones listed here, healthcare, education, et cetera, is estimated to raise $7 billion a year. So if we match the 7.25% current sales tax on goods, you get 50 billion. So it's probably not scalable to the kind of $120 billion range, or to get there, you would need a 17 or 18% tax, which is hard to imagine. As with the gross receipts tax, if wages increase, there'd be the big increase in federal payroll and income tax payments that I have talked about a few times already. It would increase neutrality a little bit in that right now there's an incentive to buy services rather than goods, or to call, if you can turn a good into a service, you avoid the tax. This would reduce that. Less volatility than some of the other revenue sources, but substantial additional resources for tax collection and auditing needed. And then finally, on the broad-based taxes, we could imagine a general increase in California income tax. This is the most progressive of the options that I've considered today. The legislative analysts estimated that for each 10% increase in a tax bracket, California would get another 10 billion a year. So if we thought of trying to raise 100 billion, that would require doubling the California income tax, which I think many people would recoil at. But if it were enacted, it would be more progressive than other ways of raising the revenue. Although, like the sales tax and the gross receipt tax, a big concern about this is that the first thing that would happen is that if employers were no longer paying for health insurance and they were required to or voluntarily increase workers' wages, federal income tax and payroll tax receipts would increase a lot. There'd be a little concern. The Congressional Budget Office has raised some concerns about reduced labor supply from higher income taxes. Some concern, and there's some concern with all these taxes about would people or firms leave California. California does already have a pretty high income tax. Most of the evidence we have is that people don't move around the country much based on income taxes, but we don't have any evidence about an instance of a state doubling its income tax. It is more volatile than other forms of taxes. We have a way of collecting it. I want to remind you that I've summarized here or provided some information about broad-based revenue sources and how they stack up against the criteria that we've suggested as potential criteria. There are, as I mentioned, a variety of smaller and supplementary revenue sources that could be considered. And so to conclude, our current system of employer-based financing is not based on ability to pay. There are a variety of options available to create an adequate and more equitable financing system. I think in Vermont, when they worked on single payer, one of the big stumbling blocks was how is it going to be financed? And clearly that's a hard question. I presented information today that I hope suggests that there are a variety of ways in which this could be financed. It's not impossible question to answer. One single revenue source is unlikely to be adequate to cover the entire need. Revenue sources can be mixed in complementary ways. And then just as a reminder, because I know you'll remind me, we don't know exactly how much money is needed, so it's a little hard to discuss intelligently how to raise it. But I think even without knowing exactly how much money is needed, we can still have a very fruitful and productive discussion about the criteria to evaluate financing options and the advantages and disadvantages of alternative options. I very much look forward to your questions and to hearing what I'm sure will be a robust and a fascinating discussion on August 13th. Thank you very much.